Hi, my name is Paul Khalil, and I am going to be discussing the serratus anterior plane block with you. I am coming to you from Nicholas Children's Hospital in Miami, Florida. I'll go over my goals and objectives, including the indications, which probe to use, some normal anatomy, and an illustrative case. The primary indications for the serratus anterior plane block are when you're putting in a chest tube, particularly after a pneumothorax or for rib fractures. Of note, the lateral rib fractures seem to be anesthetized better with this block than other parts of the rib. When you do a nerve block or any procedures, you should always know the complications. And particularly for this block, there's always the risk for infection whenever you insert a needle. If you're doing this for a rib fracture as opposed to a pneumothorax, it could cause a pneumothorax. And with any sort of block, there is the risk of LAS syndrome or local anesthetic systemic toxicity, which results in seizures. So whenever you do one of these proximal blocks, make sure you have IV access as well as lipid emulsion therapy available. Generally, I use the linear transducer because you are going for a block that's pretty superficial and you want that high quality image that the high frequency probe allows you to have. Okay, the anatomy. So what you are trying to anesthetize is the hemothorax dermatomes T2 through T9, specifically the lateral branches of the intercostal nerves. Of note, this is a plane block, so you're aiming your needle in a plane to inject your anesthetic as opposed to other nerve blocks where you are aiming your needle at a specific nerve. There are two approaches that you can use when doing this block. You can either come from the anterior approach or the posterior approach. And when doing this, you will be injecting the fluid either above or below the serratus anterior muscle. If you're going above in the anterior approach, you'll be between the pectoralis and the serratus anterior muscle. If you go below, you'll be between the rib and the serratus. If you're coming from this posterior, it's similar, except when you go above, you will be between the latissimus dorsi and the serratus anterior muscle. So when you do this, make sure that you have your room prepared with the ultrasound in front of you and all of your supplies bedside. Make sure that you have the patient positioned properly so you can have them either supine or decubitus with their arm above their head to expose the ribs. Make sure you pre-scan, prep the skin, and use tegaderm or probe cover. This is not a sterile procedure like a central line, but you should still have a clean procedure with tegaderm above at minimum. Again, when you prepare your room, make sure you have everything where you'd like to use it. The probe should be directly in front of the ultrasound screen, should be directly in front of you so that when you're looking at the screen as opposed to the probe, your needle doesn't deviate to the left or the right. In this image, I show you the anterior approach, which is what I have done in the past. So you'll be going between T4 and T5 mid-axillary when you insert your needle. This is an in-plane approach, so the needle is coming directly into view. Here is the anatomy of the anterior approach. On the dotted line at the top, it shows the pectoralis muscle with the serratus muscle in between the solid lines. The solid arrow indicates the rib, and the dotted arrow is the pleura of the lung below. In this image, you see the needle coming in from the left with the two solid arrows with the fluid indicated by the two separate solid arrows. Again, the dotted arrow is the pleura. Some pearls and pitfalls. Make sure you always have your equipment where you want it before you start the procedure. A J-tip is a handy tool because it anesthetizes the skin prior to injecting the needle, and often this is the most scary part for the child is when that needle first comes in. And always have lipid emulsion therapy available. So next I'll talk about an illustrative case. I had a 16-year-old male who came in from an urgent care where he presented for chest pain that started earlier that day. He said that the pain was substernal in the left upper chest, and it was described as constant but worse with inspiration. At the urgent care, they got a chest x-ray and demonstrated a spontaneous pneumothorax. His vitals were stable. He didn't have any tracheal deviation, so they sent him over to the Children's Hospital for further management. At the Children's Hospital on his arrival, his blood pressure was 128/72. Heart rate and respirations were a little bit elevated at 110 for the heart rate and 30 for the respirations, but his oxygen was 100% on room air. On physical, he had decreased breath sounds on the left, and there was no tracheal deviation. So when he first arrived, I threw an ultrasound on to confirm the pneumothorax. As you can see on the left, there's no lung slide. On the right, you see good lung slide. Here you see M mode with the going back and forth between lung slide and not, with the sandy beach being our normal lung with the barcode sign indicating the pneumothorax. Here you see the block in live video form. You see the needle coming in from the left-hand side going towards the rib underneath the serratus. After about 10 minutes, when the anesthetic kicked in, a pigtail chest tube catheter was placed with good anesthesia and pain control. He was admitted to the floor where they noted that the pneumothorax resolved, the chest tube was removed, and he was discharged. 2 days later, he returned to a different outside hospital where a pigtail was placed under sedation, where they used etomidate and Dilaudid. When the patient arrived back to the Children's Hospital, he stated that he preferred the nerve block as opposed to sedation because he had continued pain control with the block, as well as he just didn't like how the sedation made him feel. So, summary and key take-home points. The Serratus block is safe and effective in non-emergent chest tube placement. Preparation is key, and know your complications before you do any procedure. And my name is Paul Khalil. I am the ultrasound director at Nicholas Children's Hospital in Miami, Florida, where I did my PEDS residency and my PEM fellowship. I did my POCUS fellowship at Denver Health, and I worked at Louisville Norton Children's Hospital for a couple years before returning to Miami. My research interests are regional anesthesia and musculoskeletal, and you can contact me at my email or find me at my Twitter handle. Here are my references, and I thank you for listening.